people would be sitting in the auditorium, or they would be in their offices.
Okay,
Now,
very good. Very good. Excellent. All right, I think we're getting to a fairly good number. I'll wait maybe one more minute. Jen, anything else for us to be aware of for today?
No, usually about 12:02 is the best time when attendees start picking up.
Yeah,
Yep.
we'll wait. We're almost there. We're at 21. Jen and I know that Jen and I like look at the number. Usually by 12:02 we're at 25, and then you'll see Dr. Contreras. Probably another group will join at about 12:05. It's fairly busy. Our hospitals are fairly busy right now. Yep, as you see, we're about to hit the 25 mark.
Is the volume of my voice okay?
It is. It's good. Yeah, and we can see your slides, so that's perfect.
I just took mine down. So Dr. Contreras, you can go ahead and load yours.
Okay, good. So I'm going to go ahead and introduce you, Dr. Contreras. I think we're at a good point. So welcome everybody to our Roy Behnke Department of Internal Medicine Grand Round series. So here we are on another Thursday, and we are blessed to have an outstanding speaker. This is Dr. Gabriel Contreras, or Contreras. That's pronounced better. Dr. Gabriel Contreras. He is a professor of medicine from the University of Miami Department of Medicine. Dr. Contreras was a fellow in nephrology and also a fellow in critical care at the University of Miami in the 1990s, joining the faculty after finishing his training. Those were the heydays of Dr. Richard Preston, Dr. Mark Gelbard, Dr. Danny Lickstein, and Dr. Richard Schiff, some great names that I have been able to interact with over the years at UM. And during that time, Dr. Contreras joined the faculty. He was joined on the faculty by other superstars like Alex Machaber and Leonardo Tamaris, who very much shaped the next 2 decades of the University of Miami Department of Internal Medicine and College of Medicine. Dr. Contreras has no fewer than 30 articles that have impacted general hypertension and nephrology that have been published, and his work in lupus is even more impressive, with no less than 50 major journal articles that have impacted the care of lupus nephritis. So it is a true pleasure to have Dr. Contreras join us from Miami to discuss his topic, which is evolving therapies for lupus nephritis, from corticosteroids alone to multi-target therapies in 2023. Thank you, Dr. Contreras, for joining us from UM.
Thank you very much for your kind invitation. And it is an honor, really, to present at your institution. You know, this is a topic that I always been interested since the beginning of my, my nephrology career. Here are the learning objectives. I'm going to describe the target of therapies for lupus nephritis. I'm going to describe also the lupus nephritis histological classification and factors associated with poor outcomes. And then I will discuss the benefit and risk of cyclophosphamide therapy in the 80s and 90s. Subsequently, I'm going to describe the importance of evolution to sequential therapy trials for primarily safety of the patients. And then at the end, I'm going to compare the recent multi-target therapy trials done over the past 10 years. This is my disclosure. Now, this slide illustrates the abnormal processing of nucleosome in SLE patients and the autoimmune response, starting from increased, apoptotic cells that release fragments of nuclear DNA that are captured by antigen-presenting cells and presented to T cells. This is what we call the first signals. Now, for activation of T cells, you need a second signal, which is the co-stimulatory interaction between proteins in the antigen-presenting T cells. When these T cells are activated, they start the transcriptions of cytokines. One of the most important is interleukin-2 that finish activating not only T cells, but also B cells that subsequently, with the help of other proteins like B lymphocyte stimulator, APRIL, transform these B cells in antibody-producing plasma cells. Now, so this schema has different areas where the therapy can target this abnormal autoimmunity. You can have therapies that essentially are anti-proliferative therapies for T cells and B cells, and I'm going to talk about them in subsequent slide. You can have also antibodies or other forms of humoral therapy that can block second signal. We have also calcineurin inhibitors that can block the transcription of interleukin-2. And we have also other more specific target antibodies against CD20 antigens in B cells, and also antibodies against the B lymphocyte stimulator protein. Now the lupus classification, the last revision was made in 2018, and they classify lupus in 6 different groups. Let me say that it's not a continuous of the same disease. Most of the patients will develop one class, and only about a third will transfer to a different class. Now, the most aggressive and damaging classes are class 3 and class 4. Those are what we call endocapillary hypercellularity or proliferative GNs. And also class 5, which is the membranous, primarily because membranous manifests many times with nephrotic syndrome and substantial edema and overload problems. Now, we took a look of the effect of the histological class of lupus has on the outcome of remaining free of doubling creatinine, end-stage renal disease, or death. And we confirmed what other groups before us has described, that classes 3, 4, and 5, those are the ones that have a carry a worse prognosis. And patients with those conditions, they either progress to chronic kidney disease or die from the disease or adverse event from therapies. Now, another histological characteristic that affect the outcome is the degree of crescentic changes in the biopsy and fibrosis. What you see here in this Kaplan-Meier plot is the probability of remaining free of doubling serum creatinine. Those patients that have in the histology significant amount of cellular crescents with fibrosis, they over time, they don't do that well. And they tend to progress and double the creatinine compared to those without crescentic changes or fibrosis, fibrotic changes. Now, but there are other factors also associated with increased risk of chronic kidney disease, and I listed them in this slide. Most of these factors have been identified in multivariable models in observational studies. African American Hispanics, they don't do that well compared to Caucasians with lupus nephritis. For some reason, male gender is frequently found as a risk factor for poor outcome. The same if the disease onset is early in life, if the disease is accompanied by hypertension, by renal dysfunction, nephrotic range proteinuria anemia, anticardiolipin, antiphospholipid syndrome. If they don't respond and there is a lack of remission or they relapse, those are also other factors associated with increased risk of chronic kidney disease. I'm going to focus primarily on lack of remission and relapse and the effect that that has on poor outcomes. But let me start with this study done by the Northeast group in the 80s. This is an update, more recent update, where they assess the value of complete remission or partial remission and the probability of remaining free of end-stage renal disease or a serum creatinine no lower than 6 milligrams per deciliter. Patients that respond well, and in this particular study, they use cyclophosphamide as the induction regimen. Those that have complete response defined as a serum creatinine no higher than 1.4 and proteinuria no higher than 0.33 grams a day, they did fairly well over time. Patient with partial response, those that had only a 50% drop in the proteinuria, but they remained with levels between 1.5 and 0.3 grams a day, and they have and remained with they have an intermediate response compared to those that did not respond to the induction regimen. Now, respond in this study, complete response, the median time to complete response is large. It's about 10.5 months. It's shorter for partial response of 5.8 months. I always tell the patients that come with active lupus nephritis, who we discuss the treatment, that the treatment is prolonged, and they need to be patient and be aware that the response is not going to happen from one month to another one in most of the patients that receive induction regimen of any kind for active lupus and severe lupus. Now, another factor that in the last 20 years have shown to be also a good marker of outcome is the level of proteinuria at 24 months after initiating the treatment, the induction treatment for active lupus nephritis. Those that by 24 months achieve a urine protein of less than 0.8 grams a day, they do fairly well, and they remain free of chronic kidney disease, defined in this study as an estimated creatinine clearance less than 60, compared to those that remain fairly proteinuric with proteinuria of 0.8 grams or more at 24 months of initiating the treatment for active lupus nephritis. Another factor that anticipate the outcome of the patient is whether they have relapses, and particularly nephritic relapses defined in this study as an increase in serum creatinine of at least 30%. Active urine sediment means either a cellular CAS or microscopic hematuria and increased proteinuria. Those patients over time had a poor outcome, and the probability of remaining free of doubling of serum creatinine remains very low compared to the control group in this study, those that they never had a relapse after the first onset of lupus nephritis, or they have only proteinuric relapse. Now, I'm going to now discuss the era of cyclophosphamide therapy. I'm going to mention that in the 60s and 70s, most of the studies, the treatment studies for lupus nephritis, were based on retrospective observational studies, and the only therapy used in those days were corticosteroids. Now, in the 80s and 90s, the group of the NIH, they assessed the effects of different cytotoxic regimens with corticosteroids, and they showed that they can improve the renal outcome, but at the expenses of adverse events in clinical trials. Here I have the list of 4, which I think are the most important studies from the group of the NIH, and I'm going to review them in the following sections. Now, this is the largest study completed by the NIH. This is a randomized control study where the control group received oral prednisone, and they have 4 experimental groups. One of them received oral azathioprine with prednisone, the other one oral cyclophosphamide with prednisone, another one oral azathioprine plus cyclophosphamide with prednisone, and the other one intravenous pulses of cyclophosphamide and prednisone. What you see here is the probability of end-stage renal disease. Patients that were allocated randomly to regimens that include cyclophosphamide, they did fairly well. and the probability of end-stage renal disease fluctuated from about 25% to essentially 5%. But those that were treated with prednisone alone, they didn't do that well. Now the effect and the benefit of cyclophosphamide has, however, the consequence in terms of adverse events. The patients allocated to the use of cyclophosphamide, they have a high incidence of herpes zoster that fluctuated between 25 and 33%. The patients that received therapy with oral cyclophosphamide had a high incidence of hemorrhagic cystitis, fluctuated between 14 and 17%. And those that receive cyclophosphamide, young women with lupus, they have a high incidence of premature ovarian failure that fluctuated between 45 and 71%. So the adverse events were substantial, and the group of the NIH decided to explore a short-term cyclophosphamide induction compared to long-term. And they completed this study in 1993, where they allocated randomly patients to receive monthly pulses of cyclophosphamide for 6 months only with corticosteroids, or long-term cyclophosphamide, monthly pulses of cyclophosphamide for 6 months, and then every 3 months for an additional 2 years. And what you see here is that with a short-term induction regimen of IV cyclophosphamide followed by corticosteroids, the incidence of amenorrhea is stratified by the age of the participant at the time of randomization was low compared to long-term cyclophosphamide use that had still a high incidence of sustained amenorrhea between 17% in younger females with lupus, up to 64% in a little older, defined in these studies as age more than 25. So cyclophosphamide is one of the side effects that many young women are feared for. Is a sustained amenorrhea that make them, enter an early menopause. Now, in that study, despite the benefit of reducing that substantial side effects, the problem was that short-term intravenous cyclophosphamide was associated with a lower probability of remaining free of relapse compared to long-term cyclophosphamide. Now, this study, in particularly in others, were the background to explore the use of sequential regimens with short-term cyclophosphamide or mycophenolic mofetil induction, followed by azathioprine or mycophenolic mofetil maintenance. Those studies of sequential regimen in the early 2000s in this century demonstrated good efficacy and improved safety of the patients with lupus nephritis. And I'm going to mention 3 of them in the following section. Now, this is the Aspriva lupus management study design. In that study, the patients were randomized to an induction regimen with either intravenous cyclophosphamide, monthly pulses of cyclophosphamide for 6 months, or open label oral mycophenolic mofetil. Both groups received corticosteroids. At 6 months, the ones that had responded to the regimen, they were re-randomized in a double-blind, double-dummy fashion to maintenance mycophenolic mofetil or maintenance azathioprine, and they were followed for an additional 3 years. Now, 370 patients were enrolled in these studies, all of them young as expected, with the mean age of 30 years old. Most of them, they have class 4 lupus nephritis, 61%, followed by class 5, 16%, class 3, 10%, the combination of class 5 with class 4, 7%, the combination of class 5 and class 3, 6%. Now, 70% were new onset lupus nephritis with only active lesions. 30% were patients that had a relapse of lupus nephritis and they have active and chronic lesion in the biopsy. 40% were Caucasians, 33% are Asians, 12% patients were of African ancestry, and 15% of other. 2/3 of the patients were non-Hispanic, 1/3 were Hispanics, and as expected, most of them were female, 85%. The baseline proteinuria was 4.1 grams a day. The baseline creatinine, 1.1 milligram per deciliter. All the patients received corticosteroids for 6 months. In the induction phase of the study, 185 were randomized to receive mycophenolic mofetil, doses between 2,000 and 3,000 milligrams a day for 6 months, and another 185 were randomized to receive intravenous cyclophosphamide pulses every month for 6 months. This bar graph illustrates the primary endpoint of the study. Overall response, defined as urine protein to creatinine ratio less than 3 in those with baseline nephrotic range proteinuria, or a 50% decline in the UPCR in those with baseline subnephrotic range proteinuria with a stable creatinine, no more than 25% above baseline. MMF and intravenous cyclophosphamide were equally effective. They achieved the primary response with a rate of 56.2% with MMF, 53% with intravenous cyclophosphamide. This is the study that showed that mycophenolic mofetil was equally effective in inducing remission of patients with severe lupus nephritis. Now, when you look at the percent of patients with adverse events by treatment group, they were equally safe. Now, this is a registration study. That's why you see that any adverse event was reported in almost 100% of the patients in both groups. But the important side effects that you always fear in patients with lupus that you're treating are infections. About 2/3 of the patients in each group have infections. Serious adverse event, most of them infections, were seen in about a quarter of the patients in each group. Herpes zoster was seen in about 6%, 8%, 7%, 8% of the patients in each group. Now, the second phase of the study is the one that comparing a double-blind, dummy fashion mycophenolic mofetil to azathioprine for 3 years. In that study, one of the main outcomes was the probability of remaining free of renal flare or relapse. That probability was significantly higher with the use of mycophenolic mofetil of 87.1% compared to the use of azathioprine of 76.6%, with an absolute difference of 10.5%, and the calculated number needed to treat of 9.5 patients to avoid one relapse when using mycophenolic mofetil maintenance compared to azathioprine. Now, this bar graph illustrates the percent of patients with adverse event by treatment groups, very similar in both groups. MMF and azathioprine had very similar safety profile during the maintenance phase of the study. Now, another important study to mention, published in that time in the 80s and 90s, is the Maintain Nephritis trial, a new European study where all the patients from day 1 to week 12 received an induction with intravenous cyclophosphamide, followed by oral prednisone, and all of them also received fixed doses of intravenous cyclophosphamide of 0.5 grams every 2 weeks for 6 doses with a cumulative dose of cyclophosphamide of only 3 grams. At week 12, the patients were randomized to maintenance with azathioprine, 52 patients, or maintenance with mycophenolic mofetil, 53 patients. Now, 105 patients were enrolled in that trial, most of them young, as in the prior study, with a mean age of 33 years old, most of them with class 4 lupus nephritis, 58%, followed by class 3, 31%. They have combination of class 5 and class 3 and class 5 and class 4. Most of them, 79%, were Caucasians, 12% of African ancestry, 9% of Asian ancestry, and as expected, most of them females. They have a mean baseline proteinuria between 2.9 and 3.6 grams, and a mean baseline serum creatinine of 1.02 milligram per deciliter. The target dose for azathioprine was very similar to the Aspriva study of 2 milligram per kilo per day. The target dose for mycophenolic mofetil was 2,000 milligrams a day. The primary outcome is renal flare. That probability of remaining free of renal flare was very similar in the two groups, with slightly better results with mycophenolic mofetil group. 19% of the patients in that group had a renal flare compared to 25% of the patients in the azathioprine group. That difference was not significantly different in the study, likely related to a smaller number of patients enrolled in the study compared to the Aspriva maintenance study. Now, this bar graph illustrates the percent of patients with adverse event by treatment groups, very similar in both groups, in the mycophenolic mofetil and azathioprine group. Mild infections were slightly more frequent in the azathioprine group, but severe infections were very similar in both groups. Hematologic side effects, such as leukopenia, were more common with azathioprine than MMF group, but in general, both therapies were equally safe for the patients. Now let me move now to the last part of the talk, which is the last 10 years of clinical trials and testing therapies for patients with active and severe lupus nephritis. I'm going to talk about the new multi-target therapies for induction, mostly, and I'm going to touch about multi-target therapies or therapies for maintenance and where we stand. I'm going to summarize these 4 studies. One of them is 2 publications. Let me start with the multi-target therapy for induction treatment of lupus nephritis trial. This is primarily an Asian study from China. All the patients in both groups received initially intravenous methylprednisolone induction for 3 days, followed by oral prednisone. 362 patients, 181 were randomized to receive the combination of mycophenolic mofetil, 500 milligrams twice a day, plus tacrolimus, 2 milligrams twice a day. Tacrolimus is a calcineurin inhibitor. And another 181 patients were randomized to receive monthly pulses of intravenous cyclophosphamide for 6 months. 362 patients of Asian ancestry were enrolled in that trial with a mean age of 32 years old, 90% as suspected females. Most of them had class 4 lupus nephritis, 41%, followed by class 5 lupus nephritis, 19%, 5% with class 3, and the combination of class 5 and 4, 27%, class 5 and 3, 7%. The activity index, which indicate how active is the disease, the score at baseline was 7 out of 24 points. The chronicity index, which indicate if there is already fibrosis, was 1 out of 12, being maximum of 12. The mean proteinuria baseline was 3.58 grams a day. The mean serum creatinine 0.8 milligram per deciliter. The primary outcome of that study is complete remission or response, defined as a urine proteinuria no more than 0.4 grams in 24-hour urine collection, with the absence of active urine sediment, a serum albumin no lower than 3.5 grams per deciliter, and a normal serum creatinine. Complete renal remission response was higher in the multi-target therapy group that received the combination of mycophenolic mofetil and tacrolimus of 45.9%, compared to the control group that received monthly pulses of intravenous cyclophosphamide of 25.6%. The absolute difference is 20.3%. The number needed to treat now is 4.9 patients treated with the multi-target therapy approach to achieve 1 complete response. What you see here in this bar graph is the percent of patients reporting adverse events by the treatment group. Multi-target therapy group and intravenous cyclophosphamide group had very similar safety profile. There is, in my opinion, an underreporting of serious adverse events in this particular study coming from China, which was only 7.2% in the multi-target therapy group and 2.8% in the intravenous cyclophosphamide group. This is something that is not what we see in other parts of the world in terms of adverse events when you're treating patients with severe active lupus nephritis. Now, another important study completed 2 years ago is the Aurora trial that assessed the efficacy and safety of voclosporin and other calcineurin inhibitors compared to placebo in a regimen of multi-target therapy approach. All the patients in this study in both groups received an induction with intravenous methylprednisolone for about 2 days, followed by oral prednisone. And all of them also were placed on a background induction therapy with mycophenolic mofetil, doses between 1,000 and 2,000 milligrams a day. Now, 179 patients were randomized to receive voclosporin, 23.7 milligram twice a day was the target dose, or placebo of voclosporin with mycophenolic mofetil. Both groups received mycophenolic mofetil group. 357 patients were enrolled in the study with a median age of 32 years old, 88% women, 36% were of Caucasian ancestry, 31% of Asian ancestry, 13% of Black ancestry, 21% of others. 33% were Hispanics, 67% were of other ethnicity. Most of them, they have class 4 and class 3, 47% and 14%, followed by class 5, 14% and the combination of 5 with 3, 12%, 5 with 4, 13%. The mean baseline urine protein to creatinine ratio was between 3.9 and 4.1 grams. And the mean eGFR at baseline was 91 ml per minute per 1.73 meter square body surface area. Now, the primary outcome, complete response, defined in this study as a UPCR no higher than 0.5 grams a day, accompanied by an eGFR no lower than 60 or no lower than 20% from baseline if the eGFR was much higher than 60, without the use of rescue medication and without the need of prednisone more than 10 milligrams a day for more than 3 consecutive days or more than 7 days between week 44 and 52. The primary outcome was a complete renal response at week 52. That outcome was achieved in 41% of the voclosporin group, compared to 23% of the group that received placebo with mycophenolic mofetil. An absolute difference of 18%, number needed to treat of 5.6 liters. A secondary outcome was complete response at week 24, 32% was the response rate in the voclosporin group compared to 20% in the control group of placebo group, with an absolute difference of 12%, number needed to treat of 8.3 patients. Now, what you see here in this bar graph is the probability of achieving a UPCR or urine protein to creatinine ratio of 0.5 or less in the two groups. In the voclosporin group, the probability of achieving a UPCR less than 0, equal or less than 0.5 grams a day was about 170 days, was a little less than, a little over 3 months, by about 4 months and a half. And the cumulative probability of achieving that ninth level of proteinuria was 65% of the patient achieved that level, compared to 44% of the patient in the control group. Now, what you see here is other outcomes reported from the study. These are the mean changes at week 52 from baseline of the Selena SLEDAI, which is a way to score the extrarenal lupus. In both group, there was an important improvement of the extrarenal group, but not significantly different. In both group was a significant drop in the antibodies against double-stranded DNA, which were not significantly different. In both groups was a significant improvement, but not different in the complement C3 levels and complement C4 levels. Now, what you see here in this bar graph is the percent of patients with adverse events by treatment groups, very similar safety profile. Serious adverse events were reported in about 20% in both groups. Infections were reported in about 65% of the patients enrolling in both groups. Not much different in terms of safety signals. Now, what you see here is an important component of the report of the study is the GFR over time. Any calcineurin inhibitor has the propensity to reduce the GFR acutely or chronically. Over the study time of 52 weeks, the eGFR in the voclosporin group was not significantly different compared to the placebo group. They have an algorithm on how to modify the use of the calcineurin inhibitor. If the eGFR dropped from one visit to another one by 30% or more, the voclosporin was stopped and the GFR was repeated, and then voclosporin was restarted when the GFR recovered to the prior value at a lower dose. If the drop in the GFR was between 20% but less than 30%, there was an option of reducing the voclosporin dose. If the patient were using the maximum dose, that can be reduced to the median dose of 15.8 milligrams twice a day, or they could repeat the GFR and decide in 2 weeks what to do with the dose. If the GFR dropped by 20% or less, the voclosporin dose was maintained. Now, voclosporin is a calcineurin inhibitor that doesn't need blood level follow-up, but does need follow-up of GFR over time when you're using to treat patients with severe active lupus nephritis. And another study also published in the last 3 years is the BLISS LN trial, a 2-year randomized controlled trial of belimumab, which is a blocker of the B lymphocyte stimulator for lupus nephritis. This is the largest randomized controlled study published so far. In active lupus nephritis, 446 patients with active lupus nephritis were enrolled in the study. With active lupus nephritis and biopsy within 6 months of enrollment, classes 3, class 4, class 5, and the combination of class 4 and class 5, with a minimum proteinuria of 1 gram a day at baseline and a GFR no lower than 30 mL per minute. All the patients received a background or standard of care induction regimen that consisted of initially intravenous pulses of methylprednisolone for about up to 3 days, followed by oral prednisone with either mycophenolic mofetil as a standard of care or an induction regimen of intravenous cyclophosphamide, fixed doses of 0.5 grams every 2 weeks for 6 weeks, followed by azathioprine of 2 milligrams per kilo per day. The patients were randomized to receive placebo or belimumab, doses of 10 milligrams per kilogram IV at the time of entry on the study, 2 weeks, 4 weeks, and then every 4 weeks thereafter up to 104 weeks. The mean age of the population was 33 years old, young population expected, most of them as expected females, 88%. 33% of Caucasian ancestry, 50% of Asian ancestry, 14% African ancestry, 2% Amerindian ancestry, and 1% of other ancestry. Most of them, 58%, had class 3 or class 4 active lupus nephritis, followed by the combination of class 5 with class 3 or class 5 with class 4, 26%, and 16% has class 5 lupus nephritis alone. The mean urine protein to creatinine ratio was 3.4 grams at baseline. The mean baseline eGFR was 100 ml per minute per 1.73 meter square body surface area. The primary outcome of the study was defined as a UPCR no higher than 0.7 grams per deciliter. Compared to the Aurora 1 trial, the UPCR used in this study was about 0.2 grams higher, the cutoff value, accompanied by eGFR no worse than 20% from the pre-flare value. And in the absence of pre-flare value, a GFR no lower than 60 ml per minute. The composite definition of the primary outcome of this study for eGFR and the need for therapy was the same as Aurora. The only difference is the UPCR. Now, what you see here in this graph is the primary efficacy renal response of the study over time. By 24 weeks, the primary outcome response was reached about 40% and was maintained until the end of 43% in the belimumab group compared to the control group of 32.2%. An absolute difference of 10.7% and number needed to treat of 9 patients to achieve a primary renal response. 9 patients treated with belimumab to achieve 1 renal response compared to the control group. What you see here is the proportion of patients with proteinuria achieved from 0.5 grams per gram of creatinine excretion or higher at baseline to less than 0.5 gram, which is the cutoff value used for the Aurora trial. By 104 weeks, 67% of the patients in the belimumab group achieved that level of proteinuria or UPCR less than 0.5 compared to 56% in the control group. Now, in the belimumab group, 50% of the patients achieve UPCR less than 0.5 by 252 days, about 2 months and a half longer than in the with the use of calcineurin inhibitors and CellCept in the Aurora trial. That was 50% or time was about 170 days compared to 252 days. What you see here in this bar graph is other endpoints, mean changes of SLEDAI that assess the activity of lupus, the extrarenal activity of lupus, and percent changes of anti-double-stranded DNA levels, C3 and C4. In both groups, there was an important and significant improvement of the extrarenal group that was better with the use of belimumab with a p-value of 0.04. In both groups, there was a significant change and improvement in the level of antibodies against double-stranded DNA, but was significantly greater with the use of belimumab, with a significant difference compared to the control group. In both groups, there was an important and significant improvement in the level of C3 or complement C3 and C4 with p-values that were not significantly different between the belimumab and the placebo group. Now, what you see here in this bar graph is the percent of patients with adverse events by treatment groups. In both groups, the safety profile was very similar. Serious adverse events were reported in 30% of the patients in the control group or placebo group compared to 26% in the belimumab group. All infections were reported in about 47% in the control group, 44% in the belimumab group. Zoster in incidence was 4% in the placebo group, 6% in the belimumab group. Now, so where do we stand with the current treatment for lupus nephritis? This is why I think we stand for. Is my own opinion. You know, the KDIGO and other bodies don't yet recommend to start with multi-target therapy approach. In my opinion, the safety profile of the Aurora study and the BLISS-LN study demonstrate that there's no problem to start aggressively somebody with severe active lupus nephritis. And in my opinion, there are 3 different induction regimens that you can use. You can use MMF with calcineurin inhibitors and corticosteroids. You can use MMF with belimumab and corticosteroids, or you can use induction with pulses of cyclophosphamide azathioprine and corticosteroids. There's one error here. That would be 12 weeks of cyclophosphamide, azathioprine, and corticosteroids. And then for the maintenance therapy, we have available mycophenolic mofetil with corticosteroids or azathioprine with corticosteroids. The conclusion is that multi-target therapy achieve high rate of remission with a higher risk of adverse event, but there are some remaining questions. And I have, in my mind, I have two of them. And one of them is, does prolonged use of multi-target therapy maintain the efficacy and safety? It seems that more studies are needed, longer studies, particularly to assess the risk of relapse and long-term nephrotoxicity of multi-target therapy approaches. The other question for induction that in my mind still remain is 50% complete remission with multi-target therapy enough? Or do we need to achieve a better response? So in the long term, in 10 years or 20 years, we're going to see a difference in the incidence of end-stage renal disease, particularly in patients of non-Caucasian ancestry. For the maintenance therapy phase, mycophenolic mofetil seems to be the preferred maintenance therapy with better response, but it's more expensive than azathioprine. The remaining question is for when you can stop the maintenance therapy. And I'm going to submit for you to be aware of the mycophenolic mofetil withdrawal study that is currently in review for publication. It's an interesting study that tried to answer this question to some extent. And I'm going to open for questions, and thank you very much for your attention.
Thank you very much,
Dr.
Dr.
Yee?
Contreras. Yeah, thank you. So I see some hands already and some applause already. So Jen will direct the hands up. Jen, go for it.
Sorry about that. Dr. Yee, do you want to take the mic?
Yeah. Hi, we're here a group in the nephrology clinic, but we turn in. We don't want to miss. It was a great lecture. Thank you for giving it. My question goes, I mean, we certainly have some patients with class 3, 4, and perhaps some 5 that you can put on remission on CellCept and prednisone. So even though on studies we understand that perhaps you can achieve larger percentage with multi-target therapy, why do we need to treat everyone with multi-target therapy?
That's actually a good question. You know, and I'm going to give you my opinion. I don't think that we have that answer yet from the studies, but in my opinion, African Americans, they're still progressing. Now, I just look at the most recent US RDS report of the incidence of end-stage renal disease in African Americans in the past 4 years. They're still progressing to end-stage renal disease. I'm talking about end-stage renal disease related to lupus nephritis. Despite that, we're treating them with mycophenolic mofetil, which is very effective on them. In most of them, they're still progressing. And I don't know the answer. And I don't know if there is any study that has focused on them to answer that question. So, and I didn't present you here the subgroup analysis according to ancestry response. And that's something that I'm going to present in the AKF in a week from now. When you look at the subgroup analysis in the BLISS-LN, the control group, placebo group that were treated primarily with MMF and were in the subgroup of African ancestry subgroup, they didn't have the same response than the other patients to the multi-target therapy approach, to the control group, to the control therapy with mycophenolic mofetil. They have a lower response rate. But when you look at the Aurora subgroup analysis, according to ancestry, African Americans responded the best, really, when you look at them, to the combination of calcineurin inhibitors and MMF. When I see that type of, that observation of African Americans still progressing, to end the renal disease. We don't know what it is. We don't know if it's the treatment that maybe we're not achieving enough complete response yet on them, or whether there are other factors other than the therapy. It made me wonder that we need to explore more therapies. And when I saw these results, the safety profile of these two studies is telling me that there's no more risk of combining, calcineurin inhibitor with CellCept than just CellCept alone. I mean, we have the experience also from transplant. In transplant, they've been using triple therapy as the most important regimen, and they haven't seen really an increased risk for adverse event in kidney transplants.
Yeah. That came here from the clinic in the Aurora. Remind us the proteinuria was used as the surrogate endpoint for progression at 52 weeks?
Yes, 52 weeks.
But right, it's not surprising if you're on calcineurin inhibitor plus CellCept versus CellCept alone, yeah, you may see a little bit more response on the calcineurin inhibitor group.
Yeah, I'm not surprised too, and you're right on the money that you expect to see better proteinuria response because of the non-immunologic effect of calcineurin inhibitors on the on maintaining the integrity on synaptopoding. You're completely right. So that may be just an effect on proteinuria, but we don't know yet what the long-term effect will be on the patients. You're right. You're correct.
Thank you.
You're welcome.
All right. I think that might be it. So we thank you very much. Appreciate the presentation and even the tidy nature with the question session. We're done with 8 minutes to spare. So thank you very much, and wish you a great day in Miami, and wish everybody a great day here in Tampa. Have a good one.
Thank you very much. Bye.
Bye-bye.